Hello, my dear doctors. So today I'm going to discuss about the Mrcp PACES consultation station, and I'm going to talk a bit about thyroid eye disease. This case has presented in the Mrcp PACES consultation station, so it is important case and you should know it well. Specifically, I'll be more concerned about the thyroid eye disease. Okay, let's move on. So this is your case scenario. Mrs. Johnson's 55-year-old woman presenting with a complex medical history. She has a known history of type 2 diabetes for the past 10 years. She has hypertension for the last 15 years and hyperthyroidism diagnosed 6 months ago. She complains of recent onset of eye symptoms, including the proptosis, grittiness, and double vision. So this is the scenario, and your task is to take the complete history, do the relevant examination, answer any concerns of the patient, and then do the case presentation, and which will be followed by the questions by the examiner. So first of all, we move to the detailed history. So she has presented with complex medical history. So the presenting complaints, she is report experiencing symptoms such as proptosis, grittiness, and double vision. So patient may give this information. If not, then you have to ask specifically, because this is a case of a thyroid eye disease. So this has been progressively worsening over the past few months, and these symptoms are particularly bothersome and have started affecting her daily activities. Once you have taken the presenting complaint, then we do the system review. We'll ask about the thyroid symptoms. So inquire about symptoms which are suggestive of hyperthyroidism, such as weight loss, palpitations, heat intolerance, increased appetite, tremors, and mood changes. Patient has a history of diabetes as well, so going to ask some questions about the diabetes. So we'll ask about symptoms which are related to diabetes, including polyuria, polydipsia, any weight changes, and fatigue. Patient also has hypertension, so we would like to explore symptoms which are associated with hypertension, such as headaches, dizziness, blurred vision, or chest pain. So as you know, this is a consultation station, so we have to have a multi-directional approach, and we need to cover all the systems and all the complaints. In the medical history, we know that patient has diabetes, so we want to know about the duration of the diabetes, any treatment regime, how is the recent glycemic control, any history of diabetic complications, especially we're talking about neuropathy, retinopathy, or nephropathy. Obviously, we want to ask about the duration of the hypertension, about the treatment, how is the recent blood pressure readings, and any history of target organ damage to heart or kidneys. And thyroid disorders, we also want to ask about when it was diagnosed, and information about the previous treatment, for example, antithyroid medications, radioactive iodine therapy or thyroidectomy, and compliance with medications, and any recent changes in symptoms. So remember that should take the complete medical history. Moving on, we will also ask about the social history. So we want to know about the smoking and alcohol use. So inquire about smoking history, alcohol consumption. And we know that smoking is a known risk factor for thyroid disease. So this history is very important. Occupation and stress level. Explore Mrs. Johnson's occupation and any recent changes in stress levels, as stress also can exacerbate symptoms of hyperthyroidism. In the family history, we want to know about the relevant family history of thyroid disease, diabetes, and hypertension. So ask if there's any family history of thyroid disease, like grave disease, Hashimoto's thyroiditis or thyroid nodules, any immediate family members, parents or siblings who have been diagnosed with diabetes, and similarly also family history of hypertension and the complications like any strokes or heart attacks. So once you have taken the complete history and you have some idea about the patient, then you will take consent and do the detailed examination. So we will focus on the following areas. First of all, the general appearances. So may appear anxious or patient may appear anxious or diaphoretic and consistent with symptoms of hyperthyroidism. We want to do the vital signs like blood pressure, heart rate and temperature. This one, if it is the blood pressure apparatus is available, you can take the blood pressure or you can ask the examiner also about the vital signs. Thyroid examination, we're going to palpate the thyroid gland for any enlargement, any nodularity or tenderness, and also we want to listen for any thyroid bruit. Then we proceed to the ophthalmic examination. We want to do the visual acuity. This we can do by the Snellen chart and to assess for any visual impairment, check for any ocular motility, assess the extraocular movements by asking Mrs. Johnson to follow your fingers in different directions of gaze. Proptosis, look for any proptosis. Exophthalmometer is not available during the exams, but just observe for any proptosis. Eyelid position, look for any lid retraction, lid lag or eyelid edema, which are common signs of thyroid disease. Any conjunctival injection and chemosis, which examine the conjunctiva for injection and chemosis, which may indicate inflammation, and neurological examination. Don't forget this. Exclude cranial nerve function. Particularly, we're focusing on the cranial nerve 3rd, 4th, and 6th to assess for any extraocular muscle weakness or cranial nerve palsies, which are contributing to diplopia. Here you can have put there some pictures here. So here you can see patient has a exophthalmos, and here you can see there is a lot of eyelid edema here on the both sides. Okay, so once you have done your thyroid examination and the thyroid eye examination, although this is a case of a thyroid eye disease, but patient has other comorbidities as well, like hypertension and diabetes. So we're going to do the relevant examination for hypertension as well. So blood pressure measurement using an appropriate size cuff and following standardized technique, and take readings in both arms. If it is available, then take the blood pressure, otherwise you can ask the examiner. And you will also mention that I was also like to check for any orthostatic changes. So this is important. And then the fundoscopic examination. So perform a fundoscopic examination to assess for signs of hypertensive retinopathy. We are all aware about the findings. We were looking for any AV nicking, any hemorrhages and exudates and papilledema. And cardiovascular examination, auscultate for abnormal heart sounds, palpate for any presence of any peripheral edema, which may indicate heart failure secondary to uncontrolled hypertension. Briefly, you have to also do the relevant examination for diabetes. So glycemic control assessment, we're going to cover in the history. We're going to ask about any recent blood glucose reading and examine for any signs of hyperglycemia like dehydration or hypoglycemia, which could be diaphoresis or tremor. Foot examination, just briefly look at the foot, inspect for any signs of diabetic neuropathy, including loss of protective sensations, foot ulcers or deformities, and check the pulses, dorsalis pedis and posterior tibial, and assess for signs of peripheral arterial disease. The skin examination will look for any signs of insulin resistance such as acanthosis nigricans, particularly in intertriginous areas such as the neck, axilla, and groin. So because this is a consultation station or it's a long station, so don't forget to examine the relevant systems. Briefly, I'm going to discuss about the management of the thyroid eye disease. This usually comes in your Viva questions. So the management of the thyroid disease is best to divide it into the endocrine management and the ophthalmic management. So thyroid function control, optimize the thyroid hormone levels through the antithyroid medications, or thyroidectomy to achieve euthyroid status and stabilize the underlying thyroid disorders. Corticosteroid therapy, if there is an active inflammation, we can use oral or IV corticosteroids, which may be prescribed to reduce the orbital inflammation and swelling, and this may be tapered over time. What about the ophthalmic management? We can prescribe some artificial tears and we prescribe lubricating eye drops or ointments to alleviate the dryness and irritation associated with exposure keratopathy. Prism glasses to control any diplopia, which is caused by the extraocular muscle dysfunction, misalignment. Eye patching or taping in case of incomplete eye closure. They help to protect the cornea from exposure and damage. Botulinum toxin injections. This is also one of the treatment into overactive eyelid muscles we give locally and may help improve the eyelid closure. Surgical options may be considered for patient with severe or sight-threatening complication. So mainly it is a decompression surgery to alleviate the orbital pressure or strabismus surgery to correct the ocular misalignment. Smoking cessation, never forget this in a patient with thyroid eye disease, because smoking is a known risk factor for worsening of the thyroid eye disease and may exacerbate inflammation and disease progression. Regular monitoring by an ophthalmologist is essential to assess the disease activity, monitor the visual function, and detect the potential complication. And follow-up appointments include the visual acuity assessment and any measurement of proptosis, ocular mobility, and assessment of corneal status. Briefly about some adjunctive therapies. Orbital radiation therapy in case of active inflammation which is refractory to medical management, orbital radiation therapy can be considered to reduce the orbital inflammation. And immunosuppressive therapies also have a role in severe or refractory cases. Immunosuppressive agents like azathioprine or mycophenolate or rituximab may be used to modulate the immune response. Patient education and support. Educate the patient about the nature of the thyroid eye disease, treatment goals, and potential complications. So mainly we need to provide the support and resource to help patient cope with physical and emotional impact of the disease. So remember this, this is a very common question. They ask about the management of the thyroid disease, divided into endocrine management and ophthalmic management, and be systematic. Let's move on to the case presentation. So once you have done your taken the appropriate history and the examination, then you have to present the case to the examiner. I have put a sample here, so you can have your own presentation style. Normally, once you start the presentation, maybe the examiner will interrupt you at any stage and will ask questions. But remember that if the examiner don't interrupt you, then you just continue with your case presentation. So here is it. Today, I'll be presenting a case of thyroid eye disease in Mrs. Johnson, a 55-year-old woman with a history of diabetes, hypertension, and hyperthyroidism. Briefly about the history, then you're going to tell something about the history. So Mrs. Johnson presents with a 6-month history of progressively worsening eye symptoms, including proptosis, gritty sensation, and double vision. On examination, she demonstrated bilateral proptosis, lid retraction, and restricted extraocular movements, which are suggestive of thyroid eye disease. Relevant history reveals a background of type 2 diabetes and hypertension as well as recent onset hyperthyroidism. Family history is significant for thyroid disorders, but there is no known history of diabetes or hypertension in her family. In managing Mrs. Johnson's thyroid eye disease, a multidisciplinary approach is essential. Endocrine management aims to achieve euthyroid status through anti-thyroid medications or other modalities. Ophthalmic management include lubricating eye drops, prism glasses for diplopia, and interventions to protect the cornea from exposure. And smoking cessation is encouraged as smoking worsens the thyroid eye disease. So almost a repetition what we have learned previously. Regular monitoring by an ophthalmologist is crucial to assess disease activity and prevent the sight-threatening complication. Surgical interventions may be considered for severe cases, and patient education and support. These are actually in fact integral part of management to address the physical and emotional impact of thyroid eye disease. So this is how you're going to present your case. So I put some of the questions which are usually asked in the exam. What are the clinical features of the thyroid eye disease? So they include, we are all aware of it, proptosis, lid retraction, conjunctival injection, chemosis, restricted extraocular movements, diplopia, and then exposure keratopathy. How is the diagnosis of thyroid eye disease confirmed? So it's typically based on clinical examination findings, including characteristic eye signs. However, we can do some imaging studies like orbital CT or MRI to assess the severity of orbital involvement and exclude other orbital pathologies. Risk factors for the development of the thyroid eye disease. The risk factors include autoimmune thyroid disorders like Graves' disease, smoking, female gender, and genetic predisposition like family history of thyroid disorders. And what is the significance of measuring thyroid stimulating receptor antibodies in thyroid eye disease? These thyroid stimulating hormone receptor levels, these are elevated in patients with Graves' disease, and it correlates actually with severity of thyroid eye disease. So measuring thyroid receptor antibodies in confirming the diagnosis of Graves' disease and assessing the risk of developing or worsening thyroid eye disease. So this is an important point that it correlates with the severity of the thyroid eye disease. What are our goals? Well, goals is to, for the management of thyroid eye disease include controlling inflammation, preserving vision, relieving ocular symptoms, and preventing long-term sequelae such as corneal damage and optic neuropathy. But these are the complications which can happen with the thyroid eye disease. How would you differentiate thyroid eye disease from other causes of proptosis? Very common questions. So it can be differentiated based on the characteristic eye signs. So like lid retraction, conjunctival injection, and restricted extraocular movements, along with the history of autoimmune thyroid disease. Complications of untreated or severe thyroid eye disease. Well, potential complications include corneal ulceration, exposure keratopathy, compressive optic neuropathy, orbital fat prolapse, and disfiguring proptosis. This is a very important question, and it is asked repeatedly, complications of untreated or severe thyroid eye disease. So remember these complications: corneal ulceration, exposure keratopathy, compressive optic neuropathy, and disfiguring proptosis. How does smoking impact the course and severity of the thyroid eye disease? Smoking is a known risk factor, remember this, and it is associated with more severe eye disease and poor response to treatment, and there is increased risk of sight-threatening complications. So this is how, this is all about the thyroid eye disease. Hopefully I have covered almost everything here, and hopefully it will help you in your preparation for the MRCP basis cases. Thyroid eye disease is a very common case, and you should be well prepared for it. Thank you very much, and I'll see you in my next presentation.